We'll now move quickly to Charles Jaffe from CEO of HL7, who will talk to us about the role of open APIs and FHIR, Fast Healthcare Interoperability Resources. That's a good one.
Well, Rob, I call it fire, but we'll try and deal with it anyway. So I looked back right before I came here, and I found a slide that I made in 1969. It was one of those that are in glass, and it had the celluloid in there. I didn't keep the whole deck because it probably weighed 40 pounds, but I looked at the slide, and it was about sharing data between patient care and clinical research. So over the ensuing 45 years or so, I've managed to be a principal investigator and work at a pharmaceutical company and even for a big data group. And now I ended up here with an opportunity to share this with you. So over the next 9.2 minutes, I'll discuss how we got there and what we can do about it to really make the promise of data sharing as possible as I believe it can be. We have relied on outmoded methods for data management far too long. I do have a little voice snippet of the CEO of IBM saying that he couldn't imagine why the world would need more than 3 personal computers. Now we're all carrying around at least 1 or 2 of them in our pockets. This came to the fore for healthcare with the Recovery Act and high-tech legislation that provided the funding stimulus for this process. This was on top of HL7's 30 years of developing messaging standards around sharing data, both for administrative use and for clinical care. Our forays into pharmaceutical data were pretty much relegated to regulatory affairs. But I think even more importantly is the seamless sharing of data amongst varying verticals in the so-called Internet of Things. HL7 is used worldwide in about 50 countries for exchanging clinical data. Most of the world, more than half of the data that's moved is on some early version of what we call V2. The efforts we've made over the last 2 or 3 decades to enhance the messaging technology have been adopted and discarded in various countries around the world. This is confounded, I think, of late with the recognition that our gold standard for clinical research, the double-blind, placebo-controlled clinical trial, is too expensive, too time-consuming, 17 years, I believe, the estimate, and produces drugs that work half the time. We can't continue on that trajectory. 4 years ago, HL7 decided we would make all our intellectual property free of charge. So there be no impediment or hurdle to adopting the technology in any healthcare arena. During the last 2 to 3 years, the focus has shifted from messaging to application programming interfaces, a way of providing a portal for all your data into the outside world and controlling the gating of that data with security and access. More importantly, the focus both in the United States and in other countries has been on making the data exchange in a seamless fashion. Whatever your definition of interoperability, it's become increasingly clear that we can't continue to silo it. As an oncologist, I'm used to the ridiculousness of a cancer database and then a breast cancer database and then a receptor positive breast cancer database and on and on. It's expensive, error prone, and hard to manage. Certainly in the healthcare arena, meaningful use drove this. It said, this is what electronic health records would have to be able to achieve in order to be certified. In a parallel effort in CEDAR, looking at ways of using information technology to drive reform in clinical research. At HL7, we undertook a project which we call Fresh Look. Suppose we got rid of 30 years of legacy development and we could start all over. But how about not throwing out the baby with the bathwater? And out of that emerged a number of critical projects, one of which was FHIR. FHIR said, we'll discard the paradigm of messaging upon which HL7 made its fame and fortune, and instead we'll look at ways of using these APIs to exchange data. The security and authorization can be handled the same way it's done on the internet, with both technology and policy to support that data access. During the last 18 months, as FHIR has evolved, as it has become a standard and gone through the ANSI approval process, we see increasingly voiced concerns about why it won't work. Not the least of which is the enormous hurdles that we have to face between regulators in different countries who have a varied notion of sharing, data protection, privacy, and so forth. My clinical colleagues, whether it's in cardiology or oncology, and even my surgical colleagues, but to a lesser degree, are concerned about the enormous investments they've made in both the registry development, their curation and maintenance, and the tremendous investment they've made in using this approach. But FHIR obviates the need for all of that. You have true distributive computing. In fact, once you develop an open API, you can query across platforms, architectures, and systems. The international community has done a great deal to drive this because FHIR is not only developed on 4 continents, but also deployed. So whether in the private sector at healthcare agencies, pharmaceutical companies, the realization that you can have access to FHIR data without the cumbersome development of registries and other protocols has really sparked interest. In the United States, the Joint Committee of the Standards and Policy Committee at ONC met October 31st of last year and said, APIs are the future of healthcare interoperability. Out of that was born the Argonaut project. Jason delivering the Golden Fleece with the assistance of the Argonauts. And on December 4th, I stood up at a podium like this and announced it. We had 25,000 tweets in the first hour. Most of that was about the fact that Cerner and Epic were in fact at this table agreeing to something and agreeing to work on the project. And since then, more than 100 companies, agencies, healthcare systems around the world have agreed to adopt the protocol. At 2 of our meetings, Taha Kass-Hout, the CMIO of the FDA, has talked lovingly about his Open FDA project, in which he said it's not simply open apps, but open APIs. And he quoted a remarkable figure, about 15,000 of them, to share FDA-level data. This is increasingly important because of the need of informing clinical decisions with phenotypic data, but even more importantly, with genomic and genetic data. Last week, HHS announced that in its Meaningful Use program in 2018, they would have a requirement for open APIs. It's now an impetus for us to not only develop the FHIR app, the FHIR platform, but also to connect with the other participants in the healthcare continuum. But for me personally, critical on this list is the research community and the data that drives healthcare decision making. So I did finish in my 10 minutes, and I want to say thank you. And during the FDA Q&A, during the Q&A to follow, we'll talk about, I managed to get this presentation on one page. It's called Fire for the C-Suite. Thank you.